We have two speakers this afternoon, and they'll be going back to back, and then I'll just give some concluding remarks. It's my pleasure to introduce to you again for a return speech, Dr. Mark McClellan. His current title is the director of the Engelberg Center for Healthcare Reform and a senior fellow in economic studies. And the Leonard Schaefer Chair in Health Policy at the Brookings Institute. But you may know Mark more as he was the former administrator for CMS, as well as the former commissioner of the Food and Drug Administration. And health economists know him more for his research. Mark has done some significant work for us in terms of about health economists' methodologies for measuring healthcare quality. His work on medical malpractice reform has had a substantial impact on the profession. And this research, I think, directed some of the work you've seen in terms of the improvements that you saw in Medicare over the time that he was the administrator there. I think it had an influence on their moves towards looking for demonstration products for pay for performance, as well as the movement towards more quality reporting on providers that is still continuing today. And many of you also know that Mark is a native of Texas, and he's just been in D.C. for many years, and so we haven't seen him for a while, and it kind of makes me think, gee, Mark, when are you going to come back to Texas, run for office, because we need your help here as well. But with that, I'm not supposed to make political statements up here. Is that correct? So I better just get off the stage and let you speak.
Thanks, Vivian. I'm glad you got in that most important part of my bio, the fourth generation Texan part. It is great to be back here at Rice, and I've been able to participate in events here at the Baker Institute on a pretty regular basis under Ed Jaragian's leadership, and with people like Vivian here, very active in all areas of health policy, including in all areas of public policy, including in health policy. And I can talk about the politics a little bit. I've actually got a mother who's running for mayor of Austin right now, partly on a platform of trying to bring a biomedical center to the city of Austin, which they really need to complement all the great work that's going on around here in Houston. And I got a lot of family here in Houston as well, so it's terrific to be back. The slot after lunch is a challenging slot, right? Because I've got to do two things. I've got to keep you awake, which is not easy to do at this time of day. And I've also got to make sure that I'm telling you something different than what you've heard before and what you're going to hear. The nice thing about the presentations today is that they are going to hit collectively some complementary big issues having to do with healthcare reform. So I'm going to try to make sure I'm not duplicative of those. I'm going to sort of point you back and point you forward as I'm going through some of my remarks as well. I come from a family of very fast-talking Texans, so I will tend to go on if you let me. If you have any questions along the way, I absolutely don't mind any interruption, but just make sure you get my attention, because it sometimes takes me a minute to stop. All right, so I want to talk to you about, if I can figure out how to move the slides forward. Just use the arrows, thank you. Several topics, and this is going to be sort of bigger picture on healthcare reform. It's something I get to spend a lot of time on, being based in Washington now. Start out with sort of the political outlook, and the odds for healthcare reform now I think are honestly better than they have been in a couple of decades. This is still a very complex, big topic, but the first 100 days, we've been talking about the first 100 days of the new administration a lot lately. A lot of things that President Obama accomplished, a lot of issues got teed up. The big domestic issue for the next 100 days, if the administration gets its way, is going to be healthcare reform. This is where they are focusing their legislative efforts. It's where a lot of activity is taking place in Congress right now, so it's a very timely conference. I want to spend a little bit of time on the political context. Obviously, the key issue motivating all of this interest in healthcare reform is rising healthcare costs. The key challenge is, what are we going to do about it? I'm going to provide some perspectives on that, mainly through the lens of some of the reform proposals that are being discussed right now in Congress. And some of you may have heard that there are some alternatives out there. There's a big bipartisan effort going on now, mainly led by senators from both parties in the Finance Committee, Senator Kennedy also working with Senator Enzi in the Health, Education, Labor, and Pensions Committee. President Obama Obama said that he'd like to see bipartisan legislation. The other alternative, of course, when you have a Democratic Congress and a Democratic president, and for those who follow the Inside Washington baseball, reconciliation language is a Democratic bill, so we're going to talk a little bit about that. And then about what might happen if we don't get major health care legislation this year. Basically, the answer is this issue is not going away. We are going to get health care reform. It just may be spread out over a few more years rather than all happening now. In talking about all this, for those of you who've heard me speak before, you know that I can't get through remarks on any topic without spending a good deal of time on actually improving the way that our healthcare system works and the way that we're approaching healthcare issues. This touches on topics that most of the other speakers today have dealt with, and I know Kate is going to be talking about this afternoon too, so I'm going to try and, again, keep the focus on something a little bit different, but I do want to emphasize that we don't have a way to sustainable healthcare reform unless we really reform the way our healthcare system works. And I'll talk about some ideas for doing that. And then finally, if I have some time at the end, what to look for in the next few months some signs of whether this is all going to actually come together or not. So the fundamental reason that we're spending so much time and effort on this issue as a nation right now is the concern about rising healthcare costs and the security of coverage. That's no surprise to any of you. You all have seen charts like this before on rising healthcare costs per person in the United States. They've doubled over the last 10 years. They're projected to double again if we stay on the current trajectory over the next 10. And so not surprisingly, in all the recent surveys have been done of the views of the American public, concerns about the economy and job security are number one, but number two or three is concerns about changing the healthcare system. In fact, the rate, if you look at, sorry, I tend to walk too, I gotta stay close to this microphone. If you look at the rate of the public's view that we need to have major change in our healthcare system is the highest level it's been in decades. Typically 70% or more Americans saying that it's time to change our healthcare system. That said, there's a real complexity in approaching healthcare reform when you get from the general concept to actual consideration of specific reform proposals. On the one hand, the public is very concerned about rising costs and the security of their coverage and maintaining that, but at the same time, they are also very leery of changes that might affect their care. And I think the next slide illustrates this, and before I show you the next slide, let me do this is part of my techniques, trying to keep you awake after lunch. How many of you all think that the American healthcare system needs major change? Hands up. Okay, I see a lot of hands. I'm not going to ask the people who don't because that was easily 70% plus, so that reflects kind of national opinion. How many of you would support healthcare reform if it meant major changes in how you get your care? The doctors you go to, the hospitals you go to, how it's delivered. A lot fewer hands, actually somewhat more than you see in typical surveys of the public. So if you look at the right-hand side of this chart first, this is a version of that first question I asked. Is the current healthcare system meeting the needs of most Americans? 66% say no, 24% say yes. This is a variant on the same kind of question as, do we need major reform? When it's asked about in the general term, general situation facing the country, most people want to see change. But that support vanishes when you make it more personal. Is the healthcare system meeting the needs of you and your family? Most Americans overwhelmingly think yes, more than 70%. And variations on this question like, would you support major healthcare reform if it significantly affected the way that you got your care? Would you support healthcare reform if you had to pay significantly more for your care? Questions like that do not get a high level of public support. So the challenge is there's a lot of public interest and real public concern about wanting changes in our healthcare system, particularly changes that could reduce their costs of care, but people are very leery of any changes that might disrupt their access to medical services. And this isn't surprising. On the one hand, healthcare costs have gone up a whole lot in real terms. On the other hand, when economists have looked at what we are getting for what we're spending, there's good news and bad news. But the good news is, overwhelmingly, the evidence seems to be that the improvements that we've had in our health as a result of greater biomedical knowledge have been well more than worth the cost. costs. In fact, studies by macroeconomists have shown that if you look at the value of the improvements in life expectancy that have occurred over the last 50, 60 years, in conjunction with progress in modern medicine, biomedical knowledge, I know all of that isn't high tech. In fact, most of it's not. A lot of it's behavior changes that we know about, like smoking and or not smoking and so forth. But if you look at any of these kinds of studies, the evidence is pretty overwhelming. In fact, these studies concluded that the improvements in life expectancy and quality of life are worth more than the improvements in every other sector of our economy combined over the last 50 or 60 years. Kind of makes sense. It's nice to have the iPods and the jet travel and the cable television and all that. But what's really nice is having the additional time to spend using it, or to look at the sunset, spend time with the kids, things like that. So people want reform. They want to do something about healthcare costs, but they're very nervous about any changes that would affect the way they get their care. So that leads me into talking about what I would like to frame as three main elements of healthcare reform. One of these is coverage. This is where people typically start. This is if you have secure coverage, that presumably is going to help you with those out-of-pocket costs, the number one concern of Americans. If we're going to provide additional coverage for people, though, we got to think about financing, and healthcare is very costly these days, so this is a big challenge that could be disruptive. And that's led to a lot of interest in this third issue, reforming healthcare delivery, reforming the way that healthcare actually works. You've talked some about that already today. Let me start with where some of the bipartisan reform proposals are. And again, one of the nice things about being in Washington is that you get a chance to be, on the upsides and the downsides, I guess, you get a chance to be directly involved in some of this work. Our group at Brookings is providing the technical analysis for a bipartisan effort from a group called the Bipartisan Policy Center. It's made up of former majority leaders of the U.S. Senate. So it's been a little bit of a rotating cast of characters. So it started out with Senator Howard Baker, Senator Bob Dole, former majority leaders on the Republican side. We're also working with Senator Tom Daschle for a while, but then he looked like he was going in the administration, but he's now back, and he's actually very much engaged in healthcare reform again, and a lot of his close colleagues are in absolutely key positions in the administration too. So he's still very much engaged in this effort. We're also working with Senator George Mitchell up until recently, but as some of you may know, he was recently tapped by President Obama to be his envoy to the Middle East. So he finally found an issue that was harder to deal with than healthcare reform, peace in the Middle East. But the point is that there's a lot of effort around making this bipartisan approach work. And I don't think that's all political talk now. I think people would genuinely like to see the president, leaders in Congress would genuinely like to see this issue be truly bipartisan and legislation on healthcare reform pass with a substantial number of Democratic and Republican votes. So how is this coming together? Well, the main focus is on, again, getting people coverage, and in particular on reliable coverage options outside of employment. Why focusing just on that piece as opposed to something that would also, sweep in employer coverage and maybe reform public insurance like Medicare and Medicaid? It was back to that survey that I showed you earlier. There is a lot of nervousness about disrupting existing coverage that people actually like, whether you're in Medicaid or whether you're in employer-provided insurance. Most Americans are happy with the coverage they have and happy with the relationships with providers that they've developed in it. And so that's why the number one principle that President Obama keeps mentioning when he talks about healthcare reform is, if you like what you have, you can keep it. So this is really focused on providing new options to people who don't have reliable coverage through their job or through eligibility for a public insurance program. And much of the focus is on this concept of insurance exchange. We were just talking about this before this session about how, looking at the model in Massachusetts where competing private insurers are participating in this exchange that has certain government rules imposed on it, like there's no underwriting based on pre-existing conditions, there's no pre-existing condition exclusion, and so forth, is the kind of model that's getting the most attention with these bipartisan reform proposals. Along with providing access to insurance options for people who don't have good coverage options through their job is the idea of providing new subsidies for those individuals. Right now, there's a tax deduction for self-insured individuals, but for most people who don't have good job coverage, they are, relatively speaking, on their own about paying for their health care. They don't get that same employer tax deduction. So the idea is to set up some kind of refundable credits, probably income related, to deal with the fact that we don't have unlimited amounts of money, and it's people who have more limited incomes, maybe people who are older, need bigger subsidies. So that would be a key element of this approach. For very low-income individuals, there's some discussion about expanding Medicaid rather than trying to put them in a competing insurance pool. And then one of the issues that's gotten a lot of the public attention, the press attention, is whether there should be a sort of publicly run or publicly managed health plan competing with the private insurance options that are available in these new exchanges. And by the way, it's whether the exchanges are state level or regional or national, all that's not settled yet either. The public plan option is also not very well defined. It's been the subject of a lot of discussion over the last few weeks as people try to hone in on what are the real reasons for it and against it, rather than just the philosophical reasons. I'll come back to that in a few minutes. In order to make these kinds of insurance exchanges work, though, several other things need to happen. For one thing, you need people to participate. If you just have an individual ability to get coverage without pre-existing conditions at a community rate level, then people will tend to buy, left up to them, when they tend to need health care. So those kinds of insurance market reforms on their own don't usually work, as states that have tried community rating have found. So going along with this, just like in Massachusetts, is a need for very broad participation. And as people have rolled up their sleeves and looked at these proposals, that basically means having an individual requirement of some kind for getting health insurance coverage with some kind of meaningful penalty attached. So that's a public debate discussion that's going to happen over the coming weeks. There also have been some discussion about whether employers should have a role to play here. The basic idea is what's called play or pay. If an employer offers coverage, then they don't have to pay any new fees. On the other hand, if they don't offer coverage and it's not a small employer, then there might be some fee assessed on the argument that, well, in contrast to individuals who are getting coverage through their jobs, these employers aren't contributing anything. That's not fair. Those of you who are labor economists, like some of our other speakers, you know that you're paid according to your productivity, and in the end, all this is going to come out of your net take-home wages. But still, this is an important issue. This has been a big issue at the state level. States like Massachusetts and California have considered reforms. At the federal level, it's a little bit more complicated because the tax exclusion for employer-provided insurance is so big. The government can't generate that much net tax revenue through these kind of play or pay approaches, as opposed to states that can. You know, if you make the fee too big, then the employers actually offer coverage, but then they take this big tax exclusion on the employer coverage side, so that the net revenue effect is more limited. For all those kinds of reasons, plus where we are in the kind of the economic downturn now, I don't think this is going to end up being a very big issue in healthcare reform. But there are some other things that will be. One of these will be the generosity of the new coverage options. You've started to see some numbers floating around about what all this might cost. One of those numbers was in the president's budget, $634 billion, remember, he set aside towards what he called a down payment on healthcare reform. And when $634 billion is a down payment, this is fairly expensive. And in fact, what some members of Congress have been talking about is coverage is kind of like what they have. They always like to talk about the federal employees health plan, standard option, Blue Cross, is kind of a model plan. Well, it turns out that providing relatively affordable subsidized versions of coverage like that would be very expensive, probably $1.5 trillion, $2 trillion between 2013 and 2019. And not only that, many people who have private insurance today have coverage that is through their employer, have coverage that is not that generous. Typical employer plan, you guys know here in Texas, probably is, maybe $2,500, $5,000 out-of-pocket limit, $1,000 deductible. That's much less generous, or significantly less generous than an FEHB plan. So the alternative would be to provide less generous coverage requirements. Again, talked about this being a requirement before, and less generous subsidies to go along with it. But that gets back to the core problem of why Americans wanted help with their healthcare costs in the first place. If what the government actually delivers is a $5,000 deductible, catastrophic plan, is that really going to be enough to meet the political concerns here? The other types of concerns, going back to the earlier slides that I showed, go to disruption of existing coverage. People still have the managed care experience of the 1990s in mind about being forced into something that may be more restrictive and certainly is unknown. Those kinds of concerns about disruption make it very easy to attack reform packages. Whichever side you're on, you fill in the blank. Blank is going to restrict your access to doctors or new technologies. Blank being government-run bureaucracy is going to restrict your access to new technologies. Or blank is private health insurance plans. You just can't trust them. They're going to restrict your access to new technologies. And with the uncertainty, the complexity involved, it can be hard to get public support for these kinds of reforms. And as I mentioned before, there's some real controversy around having a public plan competing. Could this be done with a quote-unquote level playing field? Why do we need it? And so forth. And then most importantly is the financing. It is, as I said before, this is quite expensive, and this is on top of healthcare entitlements, our existing healthcare entitlements being probably the number one fiscal threat to the country. Kate is going to talk more about these kinds of numbers in a little while. Suffice it to say that we're spending probably over $1 trillion a year now on what I consider our three healthcare entitlements. So it's Medicare for people over 65, Medicaid for low-income, disabled individuals and families, and third healthcare entitlement is the uncapped subsidy for employer-provided health insurance. That's probably about $250 billion this year altogether. Put those three together, that's more than $1 trillion that once our economy recovers, and it will sooner or later, the majority of our projected tax revenue increases way out into 2025, 2050, retirement of the baby boom and beyond, are automatically going to be consumed by the expected growth in those existing programs, not to mention anything about new subsidies to assist people who don't have good coverage options now, like I was just talking about a minute ago. So how do we finance all of this? Well, that's a big challenge. Some of the ideas on the table include reforming that tax treatment of employer-provided health insurance. Kate is going to talk more about this in detail. Other sources of financing include finding ways to make healthcare costs lower elsewhere, follow on biologics. Be happy to talk more about that, comparative effectiveness research. I'm going to talk more about that in a few minutes. And basically funding reductions in Medicare. I'll come back to that as well. Or other kinds of new taxes or fee increases, something that's starting to get some discussion in Washington, or fees or taxes on sugary sodas, or another increase in the cigarette tax, things like that have some kind of connection to public health or health improvement. And then finally, where I want to spend a bit more of my time today is on reforming healthcare delivery. Why is that so high on the list? Well, two reasons. One is there's some clear gaps there, and the other is people are getting desperate. There's no other easy way to finance the kind of coverage subsidies that are needed to make affordable insurance available to everyone in our current system. This may not be the way things go. There's been some discussion recently about so-called reconciliation rules, where the idea is the Democrats could pass something in the Senate just with Democratic votes. They can do that anyway now, or will be as soon as Al Franken gets declared the winner in Minnesota. But even either way, there will be some legislation moving, particularly out of the House of Representatives soon, that differs from the kind of bipartisan package that I talked about a few minutes ago. It It will probably have more generous coverage in it. That's something that's very important to some of the core Democratic base. It will have more federal standards, more requirements for what that coverage consists of, as opposed to flexibility and opportunities for plans to compete and innovate. It will have a public plan in it, public plan option, probably like Medicare. Again, that's something that seems very important to the core Democrats. It will probably have more, as I said, more extensive federal oversight, maybe through a quote-unquote independent health board that would provide at least more explicit governance of benefit design and coverage and payments and things like that in the public plans, which would include Medicare, as well as this new public plan option for people who are under 65 and purchasing coverage through the new exchanges. And all of that means that there are going to be some additional sources of financing needed. Sources include reducing payments in the private plans in the Medicare program, imposing some tighter price regulation in Medicare and Medicaid, and possibly some other tax increases. Remember, that's what President Obama proposed to pay for his down payment on healthcare reform, a combination of reductions in payment in Medicare and new taxes, particularly on people in the highest income tax bracket. So you will see a proposal like that moving forward. The question is, which of these is going to come out in the end? Maybe neither, because of the political complexities that I've already talked about. That doesn't mean nothing will happen. We are definitely going to have some major healthcare legislation come out of Congress this year. At a minimum, it's going to include some significant reforms in the Medicare program. This has to happen because under current law, payments for physicians in Medicare are scheduled to be reduced by 21% on January 1st, 2010. Don't worry, doctors in the audience, that will not actually happen. As you know, this is a recurrent pattern in the way that Medicare works. There's a scheduled price reduction, and it ends up getting addressed at the last minute, basically by spreading the price reduction around to other payers and maybe the Medicare Advantage private health plan program in Medicare. But that's going to provide a vehicle for many of the other elements of healthcare reform legislation that might otherwise get stuck if a major healthcare reform bill doesn't go through. And in particular, that's going to be an avenue for a lot of the delivery system reforms that I've mentioned that do seem to have a significant amount of bipartisan support. I mean, it's back to this issue of kind of general bipartisan recognition that we can't afford to provide subsidized coverage to everyone in anything like our current healthcare system. So that brings me to this point about how do we actually bring down costs? Not how do we provide new subsidies, how do we raise taxes or get new revenues into our healthcare system, but how do we actually bring down costs? Well, there is a tried and true approach here. I just talked about it in the context of Medicare legislation, which is that costs go up at a rate that seems quote unquote unsustainable. So what do? We squeeze down the prices that we pay to providers. This is tried and true approach in Medicare. In fact, Medicare has built it, Congress has built it into Medicare legislation, the so-called sustainable growth rate. If costs for physician-related services go up faster than growth in the economy, basically, then those prices are reduced across the board to try to get them back in line. Now, because that happens year after year and has happened year after year, Congress ends up having to do further legislation, just like they're about to do now, to try to head off what would otherwise be very large reductions in physician prices. But they typically do it by spreading around these price reductions to other payers. It's the same principle of squeeze down the prices when we can't think of any better ways to keep overall healthcare spending on a more sustainable path. And as you know, when this happens, I think Jamie talked about this before, in a fee-for-service payment system, you get paid more for more services. You tend to get more, I think Jamie used the word productivity. I don't know, I guess that's one way to define productivity, is more stuff, more billing, more visits, costs go up further, you need to squeeze down the prices again, vicious cycle. Doesn't work. So traditional healthcare reform doesn't address some of the main causes of rising healthcare costs. And remember, spending is prices times quantities. And if you just focus on the prices, you're kind of missing some of the main point about what needs to be addressed in making healthcare delivery work more effectively. The main reason why spending has gone up over the last 20, 30, 50 years has been not prices, but the fact that more people are getting treated more intensively for more health problems. A lot of that is clearly worthwhile, and I talked about that earlier. The longer life expectancy, better quality of life for people with virtually any chronic disease, with just a few exceptions. But there is growing evidence, clear evidence, and much of what you've already talked about today, and we're going to hear more about from Kate, that a lot of this treatment is not that worthwhile at the margin. A lot of evidence of overuse of medical treatment. So this is a slide. I'm going to let Kate talk mainly about these slides, showing you all have probably seen a lot of these before. This is work done by Dartmouth, a group that we collaborate with closely in some of our healthcare reform efforts. Showing variations in cost per person in the Medicare program, with some areas twice as high, 50, 100% higher than others. And yes, Houston is one of those dark red areas, which is at the high end of the cost per person spectrum. Jamie's right that this does not take into account some of the price variations from region to region, but the underlying fact remains is the cost of treating a typical person is very different in one region of the country to another. Dartmouth has also done some recent work showing trends in spending growth over the 15-year period from 1992 to 2006, showing there have been vastly different trends in spending growth from region to region. They're not always perfectly, not perfectly correlated with the high spending levels, but the point of both slides is that we're seeing very different patterns of utilization, very different patterns of resource use with similar, if not worse, patient outcomes in the higher cost or higher cost growth areas for reasons that do not seem to be leading to constructive impacts or positive impacts on patient health. As you look more closely at this, the underlying reasons are primarily not related to things like people in some of the red areas or dark green areas getting more brand name prescription drugs, and it's not even related just to having more intensive surgical procedures like bypass operations or back surgery. It's more related to more subtle differences in medical practices, particularly for the management of chronic diseases. So if you have diabetes, that most common condition, how often you go to your internist, how often are you referred to a specialist, how often you go for a follow-up visit, what lab tests are done, and how often, what imaging procedures of your heart, of your circulatory system are done, and how often, when are you admitted to the hospital, and how long do you stay. And the more subtle differences in medical practice that account for most of these variations in cost and variations in cost growth from area to area. And that's important in thinking about what to do about these variations. Is this an opportunity for savings? Well, before I turn to overuse, these kinds of statistics have been widely cited by leaders in the administration and in Congress, including the current director of the Congressional Budget Office, is saying, look, 30% of healthcare costs may well be unnecessary. There ought to be a way to get those costs out of the system without compromising quality and maybe even improving it. If the low to moderate growth areas had been typical for what this country experienced over the last 15 years, as opposed to the high growth areas. If the high growth areas have grown at 2 to 3% per year beyond inflation rather than 4% per year or more, that would have amounted to $1.2, $1.3 trillion over the past decade, which could have easily covered all the uninsured. Why can't we just redirect that money and have a sustainable, high quality healthcare system? Well, one of those things that, as you heard from Jamie, is easier said than done. I want to come back to that. Underuse is another problem. We've talked about that already today. This is probably hard to read from where you're sitting, but basically, even for people with insurance, whether it's for preventive care or care for managing a chronic disease or care for treating the complications of chronic diseases, the evidence we do have is not widely or consistently used. Only about 55 to 60% of patients get evidence-based care for these kinds of conditions. So we've already talked about, Jamie's already talked about that some. I do want to emphasize this point about prevention. and the fact that we do a pretty lousy job of preventing chronic diseases in the first place, as well as managing them. This is trends in obesity. Basically, the rates in this country have doubled between 1990 and today. As you know, people who are obese have a higher average cost of healthcare use, a higher incidence and greater severity of a whole range of conditions: diabetes, heart disease, heart failure, many common types of cancer, lung problems, arthritis problems, and so on. So all of these are contributors to our higher, to the high level of healthcare costs that people would like to do something about. I also wanted to mention misuse. Common errors in healthcare delivery are quite common, tens of thousands of deaths and billions of extra healthcare costs, and also uncertainty about what works. There's limited evidence underlying most care, even in some of these areas where the best evidence we have, where we've got guidelines for what constitutes good medical practice, is actually not based on that extensive, solid empirical evidence. So all of those are aspects of healthcare delivery, how healthcare itself is delivered, that presenting some real problems, and according to many people on both sides of the aisle for the healthcare reform debate this time around, like to see something done to address it. And there's got to emphasize there's some true bipartisan interest in having legislative changes to try to get at these kinds of quality problems, these kinds of gaps in the value of healthcare. In fact, as the bipartisan efforts in Congress have gone forward, they've started with healthcare delivery reforms. That's where the Finance Committee started with some public meetings a couple of weeks ago before they get to coverage issues, and certainly before they get to those very difficult financing issues. So they're trying to build up some momentum for why we've really got to act now. We can't afford to continue having a healthcare system with these kinds of gaps in quality and these kinds of inconsistencies. So how do you get there? How can we actually get to healthcare delivery? Well, it's one of those things that's easier said than done, as you've already heard about today. But I want to focus on some steps that I think, based on experience, can take us in the right direction, are certainly getting a lot of attention as part of the healthcare reform debate this year. And again, because there is bipartisan support, because there is going to be an opportunity to move reforms in these areas as part of Medicare legislation, even if major healthcare legislation doesn't go forward, I think they're worth talking about now, because they are probably going to be increasingly incorporated in our healthcare system in the future. A common feature of these reforms is to focus more explicitly on the goal: better quality of care, better results for patients at a lower overall cost. And in my view, at least, this requires getting to more of a system-wide approach to accountability, not just focusing on episodes, not just focusing on specific aspects of care, but focusing on accountability for the results for a population of patients. To get from here to there, I want to talk about 4 key elements. One of these is measuring what we really want: better quality and lower cost. We've touched on that already during this conference. Second is payment reform. That's important, but it's not the only thing. Third, benefits is really just another word for consumer or patient involvement in driving these reforms. It's going to be a very powerful force. And fourth is better evidence. In all these areas, I think Jamie alluded to this as well, it's also important to have our kind of system moving together in the same direction. There have been efforts on small scales to implement reforms in one or more of these areas, typically by one payer, one large employer, something like that. It can be very difficult for just one party in our healthcare system to have create enough momentum to create a critical mass for driving these kinds of reforms. So that's the thing that I'm going to come back to as well. And again, you heard about that from Jamie earlier today, and things like different health plans coming up with different measures of quality, even if they were using the same basic measurement techniques. So first of all, on measuring quality and cost, very important. And I'm not going to spend much time on this because we've already talked about it today, thanks to Jamie's presentation. There's been a lot of attention, particularly around process measures of care. Those are the ones that people tend to focus on at the physician or physician group level, because they're most under the control of individual providers, like whether or not a patient with diabetes got the right medications and the right screening tests. Unfortunately, as you heard from Jamie, these measures by themselves do not seem to be sufficient to drive both systematic improvements in quality and systematic improvements in efficiency, getting out those inefficiencies from the healthcare system that I talked about earlier. Rather, when you tend to focus on these particular process measures, maybe even pay for performance for some of them, you can get improvements in the process measures, but maybe not improvements in overall costs or in other aspects of care. So there's been increasing emphasis in focusing on bottom line results for patients, including health outcomes and patient experience measures. These are harder to measure, especially harder to measure accurately at the level of small populations of patients, as Jamie emphasized, but a lot of work going on in these areas. So examples of these include measures like proximate outcomes for chronic diseases like hemoglobin A1C levels for diabetics, what's a measure of how well their blood sugar is controlled over time, or admission rates for complications, for preventable complications. Again, you saw those kinds of examples in Jamie's slides. Also very important, I think particularly for chronic diseases, or patient experience measures. These are getting to be more widely used and more standardized, and again, for chronic diseases, patients often know better than just about anybody else what's really working for them, and having consistent information on patient experience can be an important driver for better performance. And then finally, overall costs. And I want to emphasize here, this is not just about price transparency like people have been talking about for some time now, but individual prices for individual services isn't what patients really care about. It's not really the goal of overall efficiency. This is rather, not just at the episode level, but again, getting costs down at the population level for a whole population of patients. And then finally, having efforts to make these measures consistent throughout our healthcare system are very important. We've been engaged in an effort at Brookings, working with the major health insurers nationally and the Medicare program to get to consistent ways of constructing measures of quality of care and overall costs of care without actually having to pool everybody's data together in one big black box somewhere. It's possible using what are called distributed data methods, as long as people are doing basically the same thing for similar kinds of data. You got to be very careful about the methods, but it provides a way of getting to more comprehensive measures of quality of care. Again, technically a lot going on in that area now, especially with progress in electronic healthcare. So more of that is coming. With better measures of quality and cost, it's possible to move towards payment systems, and as I'll talk about later, benefit designs, other aspects of our healthcare system that focus much more on accountability for value, for overall results. And here, again, I want to go into a lot of the technical details, as you've heard about this from some of the other speakers. I just want to give you a concrete example of what I mean. While I was at CMS, we started a demonstration program, and Jamie alluded to it, called Physician Group Practice Demonstration, that was intended to be a model for how you can move from fee-for-service-based payments to payments based on overall accountability for quality and cost. And the basic idea of this shared savings program was something like the following. The group practices that were participating in this effort continue to get paid on the basis of their fee-for-service payments, but in addition, they also started reporting on the overall quality of care that they provided for their patients. This included a set of preventive care measures like screening for cancer, use of flu vaccines and the like, and also included some process and especially outcome and patient experience or satisfaction measures for the common chronic diseases that make up most of Medicare spending. So congestive heart failure, coronary artery disease, diabetes, several of the common cancers, chronic lung disease, that's about 60% plus of Medicare spending, or patients with those conditions account for a majority of Medicare spending. They reported on the quality measures in each of these areas. And at the same time, Medicare also tracked the overall expenditures for the population of patients that got care from these physician groups. Not just physician costs, but also hospital costs, rehab costs, everything that Medicare paid for. And the deal was, if the groups could demonstrate that they were improving quality in most of these dimensions, particularly the outcome dimensions, and if Medicare observed a reduction in the overall cost trend, if the groups really were starting to bend the cost curve, then they got to keep most of the savings that resulted. And so this is intended to get at some of the problems that Jamie talked about earlier of physician groups taking steps, or providers collectively taking steps that get costs down, doing fewer of those repeat visits rather than more, substituting a nurse practitioner or someone who is trained in managing the chronic disease patients who are more complex for more costly physician office visits and for possible complications. patients, using electronic health records to prevent patients from having to go into the hospital or even go into the doctor's office. All those things don't pay in a fee-for-service payment system, so you can't invest in them and still break even in terms of net revenues. But under this kind of shared savings approach, they at least start to. And you can think of these shared savings or these accountability payment ideas as really a point on a continuum of spectrum. Imagine it at one end of the spectrum, you're just getting paid on a fee-for-service basis. At the other end, you can imagine these kind of accountability payments being a larger part or even all of your of the provider payments. In the extreme, that's capitation with some careful attention to quality of care measures. But we're talking about something in between. Not moving all the way in one direction, not staying with a fee-for-service payment system, but starting to build in more direct support for steps, whatever steps are effective in actually getting to better outcomes at a lower cost. And this does require significant numbers of patients. We did this with multi-specialty groups and also have tried it with some IPAs now too, independent practice associations, networks of providers. You need more than a practice of 30 or a few doctors, but a lot of care is increasingly delivered through these kind of coordinated care networks. If you look at how doctors are actually practicing, they tend to work with a network of other specialists in a particular set of hospitals that gets you to this level. And again, this is not the only thing in reimbursement, but it is a step away from just paying on the basis of volume intensity. Well, in that demonstration program, it's now about 3 years in, 5 of the 10 groups that are participating have reduced costs by more than 2% per year off trend. And all of the groups have significantly improved their population outcomes. It's not episode-based, it's population health-based, and they're including a lot of wellness steps and other things that, are not, again, stuff that you don't get paid for at all in a traditional disease focus and healthcare. We're now these efforts are now being expanded on a multi-payer basis. So CMS is about to approve some demonstration programs in places like Indianapolis and North Carolina that include not only Medicare payments moving in this direction, but also Medicaid payments, state employee payments, private health insurance payments together. So it's that multi-payer, that collaborative critical mass approach that I talked about before. So that's the payment reform side. I want to talk briefly about the fact that it's not all about payments. Consumers are really important, and I think Kate is going to talk about this as well, about designing benefits to focus on value too, and giving patient support or consumer support when they take steps to get better health at a lower cost, whatever it takes to get there, including things that aren't traditional health care. One microcosm of this was the experience we had in implementing Medicare Part D. So those of you who are healthcare professionals, and certainly those of you who are Medicare beneficiaries are familiar with this program, this new drug benefit in Medicare that started in 2006. That was one of the main reasons I went over to the Medicare program, was to implement this. And it's always good to start a job with low expectations, right? And back then people thought this was not going to work. It's prescription drug only insurance. There are all these estimates that costs were overrunning and everything. We had 3 main goals in implementing the program. We wanted people to find out about it. And at this point, more than 90% of people with Medicare are actually enrolled in prescription drug coverage. So the word has gotten out. We want to make it work for all different types of beneficiaries, and we did so through things like risk adjusting payments. And if you think about the Part D benefit itself, it's sort of like those exchanges that I was talking about earlier. The plans can't charge a different premium to people with different risks, and people have very different risks of drug costs, so we have to deal with that problem through things like risk adjustment and subsidies. Much has been talked about for the broader exchanges. And at this point, satisfaction rates in the program are actually very high, with close to 90% of people either highly satisfied or somewhat satisfied with the program. Not a whole lot of complaints about benefits within the program itself. And the third goal was to bring it in under expected costs. And the costs for Part D are now running about 40%, 40, below the cost projections at the beginning of 2006. There are a number of reasons for that, but the one that I want to highlight is the change in quantities that have occurred within the program. Remember, spending is prices times quantities, and what the drug plans did, or at least the drug plans that people overwhelmingly signed up for did, was change the way that they design their benefits. So Congress passed in the law a standard benefit design, which was deductible, then 25% coinsurance, then catastrophic coverage on the back end, and between that there's that famous donut hole. Y'all remember that? Which turns out if they had the cost estimates today, back then, that they wouldn't it wouldn't be built into the benefit, but you can't go back and change the numbers because they usually turn out to be much higher in these government programs, not much lower. for. Nobody today is enrolled in that kind of benefit design. Everybody has chosen plan benefit designs that have more of a tiered structure, where the generic drugs, the drugs that work just as safely and effectively as the brand name drugs, are free or almost free, $1 or $2 a month. The plans negotiate lower prices on preferred brand name drugs in most of the common categories of drug use, like for cholesterol-lowering drugs or blood pressure drugs or diabetes drugs, which will cost maybe $25 a month or so. And then most other drugs are covered. The formularies are very broad, but beneficiaries pay a larger share of the cost for the remaining medications. And it works out to the same or better actuarial value as a traditional insurance design. The difference is that from a patient perspective, you can save a lot more money if you switch to a drug that meets your medical needs at a lower cost. You get to keep a lot more of those savings than another 25% co-insurance design with an out-of-pocket limit. And the fact that people who can save the most money are the people with chronic diseases who are using multiple drugs. And what has happened since 2006 is a big shift from brand name to generics. It's gone from about 50% to over 70% of prescriptions. And those drugs cost 70 to 80% less than the brand name, so that's a huge reduction in cost. And a big shift from non-preferred to preferred brand name drugs with relatively low rates of complaints from beneficiaries. We had hired all these people to answer the phones for complaints about, I can't get access to the drugs that I need, but only got complaint rates of about 1 per 1,000 beneficiaries per month for that. There were a lot of beneficiary complaints. Why do I have to choose among all these plans? Why can't the government just come up with one design and not, so that I don't have to mess with all of this? But the result of people actively engaging in both the plan choice, which led to differences in benefit design, and the choice of drugs, most of these drug changes, if you look at surveys, were driven by the patient, not the doctor, was much lower cost of this program than had otherwise been predicted. Now, these kinds of reforms where people can save a lot more money when they get the care they need at a lower cost can become much easier to do if you have good, reliable measures of quality and cost of care. As Jamie mentioned, this is starting to happen in things like elective cardiac surgery and orthopedic surgery, where some groups are offering all-in summary prices along with really good information on the outcomes that patients care about, like complication rates and overall satisfaction rates with care. And the deal is, and there's some plans that are doing this now, you can go to your local cardiac surgeon for your bypass operation, Mr. Smith, or you can go to Mayo. If you go to Mayo, we'll pay for all of your costs, or all of your costs except for a small deductible, and we'll fly your spouse there, and we'll pay for your rehab. And look, here are the outcome measures. You can get better outcomes as well. Or you can go to a local cardiac surgeon and pay the difference in cost between what the cost is at Mayo and what the cost is with these higher complication rates and more services at the local surgeons. It's the same kind of tiered benefit design idea applied on the beneficiary side, particularly for people with chronic illnesses. Same thing goes for cancer care. There are places that are increasingly demonstrating, including MD Anderson, they can deliver better quality care at a lower overall cost. That can be built into these kind of tiered benefit designs and so forth. It could really work around helping people with chronic diseases, as opposed to traditional insurance design, where if you've got a chronic disease, especially if you're in a high deductible plan, you're automatically spending $5,000, $10,000 a year, even though there's a lot that you could do and a lot that you are doing to get better care at a lower cost. So this is a kind of reform that's increasingly coming as well. I don't really have time to talk about better evidence on what works, but suffice it to say there's a lot of attention around comparative effectiveness research and better evidence on personalized medicine. That's something that's going on a lot at the medical center here, which holds some promise, but we've got a lot of barriers to overcome. Probably not going to make a big difference in the short term. Getting these reforms in healthcare delivery done is going to require overcoming some sources of opposition, but I think these are really going to be a key part of the overall reform package that will happen this year. Looking ahead, which way is this going to turn out? Well, for bipartisan reform to work, you really need to see legislation coming out of these relevant committees in the Senate. That's where they're leading the bipartisan effort by this summer. As you get into the fall and into the political season of 2010, these bipartisan efforts are much more difficult to put together. The Democratic reform bill is also not automatic. The Democratic Party itself has a number of different factions, including many moderate Democrats who are very concerned about too much government involvement and especially too high costs down the road, worsening that entitlement outlook. So it's not a sure thing that bill is going to come together, at least with broad support within the Democratic Party. If that doesn't happen, less likely likely that you'll see that kind of reform. If neither of these moves along well, that brings you back to the kind of Medicare delivery reform package that I've been talking about as well. Whatever happens this year, just want to emphasize that healthcare reform is going to happen. There are too many underlying pressures in healthcare itself towards more personalized care, more preventive-oriented care, too big of gaps between the care that we're delivering and the care that we could deliver for healthcare policy to get too much in the way for too long. So there's this incredible pressure to move in these directions towards better, more personalized care. That's where medical technology is going, and policy can't stay too far behind for too long. So these kinds of reforms are going to happen. For those of you who are healthcare providers or employers or even patients out here, getting out in front of this, I think, is a good way to position yourself for where our healthcare system is likely to be headed. And I want to end on the point that there's a real opportunity for community leadership. The University of Texas, Ken Shines here, is taking some steps to lead delivery-oriented reforms like the ones that I've talked about today. There's some community efforts. We're working with a coalition in the Dallas-Fort Worth area. For example, their business group on health and some of the major health insurance plans are implementing some of these population-level reforms in accountability together in conjunction with support from the provider groups in the area. So this is not easy to do, but it is going to be happening. It's going to be happening either through major legislation in Congress this year, or even if not, through steps that you all can help take, and hopefully Texas can continue to help leading the way in healthcare reform efforts. Thank you very much for the opportunity to come back here and talk to you all again. Thank you. Thanks. And see, like I said, I can talk for a long time very fast, but I think we have time for a few questions, right? And can you say who you are when you...
Yes, my name is Laurie Lee. I'm with Interfit Health and Fitness Management Company. What do you think is the likelihood and the advisability of this proposed new WIP legislation whereby corporations will get tax credits for any kind of health improvement programming that they offer to their employees?
You're talking about legislation at the federal level
Yes.
now? Yeah, there are a lot of proposals like that are focusing on providing incentives for companies to undertake these holistic approaches to focusing on their employee health, and the employers who do this swear by it. I think they've got some numbers to back it up, especially if you're focused not just on the cost of health insurance, but the overall cost of health problems to the productivity of your employees, absenteeism, workers' comp, and so forth. It does seem like some of this pays off. I'd be surprised if that legislation actually moved in a kind of meaningful way. There are a lot of employers who are doing this sort of thing already. It's a little bit hard to define what it is in legislation. I mean, you know it when you see it. You know good programs when you see it, but imagine trying to write legislation that captures that, now and for the future. And the real focus is for major legislation on healthcare reform. So I could see maybe something like that get incorporated in this overall reform package, but probably, I wouldn't wait for that. That said, to the extent that there is movement in our healthcare payment systems and healthcare benefit designs to focus more on better health results, I think programs like the ones that you're talking about get support built in, because to the extent that they can get better health results for a population at a lower cost, they get more support that way.
But not a lot of optimism about this
not
legislation.
A lot of optimism about a specific tax credit, no. But they'll get some attention in this whole debate.
You.
Hi, I'm Caroline Mortensen. I'm here at Rice University. I don't have a question, but I know we have a number of very good students who have challenged the way that I think about healthcare reform and healthcare policy. I wanted to give them a chance, just in case they were a little shy, to come up on their own to see if anybody has a question. I'm Tommy or June. June, thank you.
Hi, my name is June Liu, and I work for Community Health Choice, and I'm a soon-to-be Rice graduate. I was wondering, unless I'm mistaken, technology is one of the a big reason for increases in healthcare costs.
More and more intensive treatment.
Why
and more
have
problems.
I not heard anything that addresses this factor in healthcare costs? And also, my boss just pointed out that technology actually decreases costs in other industries. why do we just assume that it's going to increase costs
Yeah,
in
really
healthcare?
good question. It's one I spent a lot of my career on. So my short answers are that if you think about technology broadly, it actually was built into a lot of what I said. So all those area variations in cost, that's in some sense technology. It's not technology like people tend to think about it, which is like the newest, latest, greatest, nanotechnology device or something like that. It's technology that's much more commonly used in routine medical practice, like lab tests and MRIs, which are just used very differently for common health problems in different areas around the country. And those are trends that happen over time that are the main reason for, if you look at it quantitatively, for the spending growth and certainly for the variations in spending from area to area. So to do something about that, again, I think the focus has got to be increasingly on what is technology doing for us. So instead of paying the way that we traditionally have in healthcare, where you use more intensive technology, you get paid more for it, at least start moving towards paying in part based on what kind of results does the technology lead to, and does it lead to lower costs. We have a payment system that supports higher cost technology through fee-for-service reimbursement. It shouldn't be surprising that you get a lot of that. When we've moved to episode-based payments, like for doing cataract replacement or even joint surgery, costs have come way down over time. Overall costs don't go down because a lot more people end up getting the treatments. If it's easier to do, lower risk, provide some real benefit, the cost-benefit rate or the risk-benefit ratio changes a lot. But it does show that the technology does respond to the financial incentives. And I think the kinds of steps that I'm talking about towards putting more of an emphasis on better results at a lower overall cost for patients could help drive the kinds of cost-reducing changes in technology that we do see in lots of other industries.
Thank you.
Hi, Mark. John Mendelson from MD Anderson. Thank you. The biggest chunk of money that is accessible that I can think of is the 19 plus or minus $1 billion for an electronic medical record. And what are the chances that instead of using that to help every doctor take his paper records or her paper records and convert them into something on their computer, which is what it sounds like that's going to go for, that this actually went for a national standardized electronic medical record that would be portable and allow us to collect data where everybody used the same vocabulary, which is very different from helping every doctor in practice to convert their records into paperless.
Yeah, so I think there's sort of three possibilities for this. So this is a legislation, the economic stimulus legislation included what's been estimated to cost $19 billion. I think it's actually going to be more like $30 billion in net financial incentives for adopting health information technology in hospitals and physician offices. So three ways that might be used. One is, and it's all related to how HHS ends up defining this term called meaningful use, because the payments are tied through additional Medicare and Medicaid payments, so add-ons to your usual Medicare and Medicaid payments for quote-unquote meaningful use of health information technology. Three possibilities. One is that a whole bunch of technical specifications are described. So this is what a lot of the health IT vendors kind of would like to see, where you've got to get a comprehensive electronic record, it's got to meet these interoperability standards, it's got to have these 3 or 4 or 5 different functions. Might happen, but a lot of people are skeptical that by itself would really lead to adoption and consistent interchange of data, which I think is what you're talking about. So another possibility is, well, let's all just buy one system. And Pete Stark has got a provision included in that legislation, which after a few years, if there's not enough progress in actual IT adoption, the government has some authority to go back and look at imposing or creating one single platform standard for the country. And the one that people have talked about the most for that is the standard used by the VA. Traditionally is Vista. They use so-called Epic systems now, some as well. But that too, just kind of imposing one standard probably isn't going to happen, at least in the short term either. And there's some people who are nervous about putting all the eggs in one basket. And they point to the UK experience, at least the first time around, where they spent literally billions of dollars and it didn't work and the features were outdated by the time the system was adopted and so on. The third possibility is one based more on functional results. And I have to say, with the new head of the Office of the National Coordinator for Health IT being David Blumenthal, who fortunately I think is not a health IT expert. He's a very functionally oriented guy. He wants to see IT deliver better results of care, higher quality, lower cost. A big component of meaningful use, at least in the short term, may be around demonstrating results, at least on a limited basis. So what is health IT supposed to do? It's supposed to lead to more coordinated care, avoid complications and things like that. Well, why not measure that? Why not have as a standard for meaningful use that you're actually using an electronic healthcare system that leads to coordination of care in some way? It leads to lower hemoglobin A1C levels for your diabetics, leads to higher prescription fill rates for other patients with chronic diseases, a functionally oriented result regardless of how you get there. And I think what we're going to end up with is probably some combination of the first and the third. My own view is that if we don't have at least some emphasis, including in these payments, on the results, on actually using the interoperable system to do something that demonstrably improves patient care, we may not get there. We've had a lot of effort over the last 4 or 5 years focusing on interoperability standards and things like that, and it really hasn't helped with a lot of progress yet.
Elaine Liu from University of Houston, and in the beginning of your slides, you mentioned that we want to reduce the number of uninsured, potentially using the individual requirement or punishment tied into the individual requirement. And I'm curious, and you mentioned there's a debate coming up soon. I'm curious, what's the method, or besides the Massachusetts method, which is tying it to the income tax filing and giving them punishment if they don't enroll in an insurance plan? Potentially the target group that we want to look at are unemployed, or they're low income, and what kind of punishment, or maybe we should say incentive, that we can give them to increase their enrollment.
Yeah, well, there's certainly some incentives that you can provide as well, and I did mention, and perhaps didn't emphasize enough, new subsidies that people would get, and there's a lot of emphasis or a lot of attention being paid now to what's a big enough subsidy to get to quote unquote affordable insurance. And obviously, for someone with income of $20,000-$30,000, they're not going to be able to pay much of the cost of even a basic health insurance plan. So they're going to need some fairly big subsidies. That's what leads to those high costs of implementing reform that I talked about, and that leads to the financing challenges that we've already talked about. On the penalty side, though, if you think of this as a combination of carrots and sticks, there's sort of a couple of things that I'd mention. I think ask Kate the same question. I think she knows a lot about this stuff too. One is just if you make it a requirement, if that's in the law, Americans tend to obey the law, so that by itself gets a lot of people enrolled in coverage. If you just have a requirement even with no penalty, by no means gets everyone, especially those who are having to pay out of pocket. So what can you do for those? There have been a lot of ideas talked about for a default enrollment. There's been studies of people are I think overgeneralizing from studies of retirement plans, where if you're automatically enrolled by your employer in an IRA or 401k, you're much more likely to stay with it than if you have to actively sign up on your own. So the idea is, well, let's do the same thing for health insurance, automatically enroll a lot of these people who don't have coverage now into some basic plan. That could help get participation up. And then I think a lot of the penalties are expected to be tax related, or perhaps participation in other types of government benefit programs. So if you don't have health insurance coverage, you can't sign up for unemployment benefits or other types of benefits as well. But I think a lot of the penalties would be through the tax system, and I think one of the main reasons for that is that if you think about the operationalization of this, the tax system is really about the only choice that we have for having individualized information related to income and related to giving people subsidies towards the cost of their insurance. There's a precedent for this. We have actually a tax credit in the law now for people who lose their jobs because of trade that people are looking at as maybe a model to build on or improve upon for this. So it also means be going through the tax system.
Hi, my name is Ken Kennegas. I'm a registered nurse, and I'm a member of Healthcare for All Texas. And this is probably more of a comment than a question. After listening to this, I think it sounds like a probably fairly realistic but very sad commentary on the prospects for health reform. To me, it sounds like a lot of rearranging of the deck chairs on the Titanic. As the last speaker said before this, we can't even get good data out of the system we have. And, the committees that are meeting, the committee that met yesterday in Washington, Senator Baucus' committee, There's one thing that doesn't come up unless it's brought in from the outside, and that is single payer. We've got to start talking about single payer. Eventually, it is going to blow, as you said. This is going to blow, and we're going to have to look at single payer. We have to get outside of the box, or the pot, whatever you want to call it. Actually, though, we're the only country, advanced industrialized country, that's in the box. Every other country has some form of a single payer type system which works, which much
I don't
more
mean to
economical.
cut. I mean, it's a very eloquent comment, and I think basically I guess 2 points. One is if we don't see progress soon, like I said, the pressure is just going to keep going up and up, and I think, things that look radical today, or things that actually people are talking about today looked radical 5 years ago, 5 or 10 years from now, with those budget trends that I talked about, things that are not on the table now, like single payer, and it's not politically, it's just not, I think will be much more in the mainstream debate if we don't make progress on things like, the competitive system, a choice-based system cannot work without good information, without personalized information, without adequate support for people with limited resources, without dealing with some of the problems that have been talked about today. If we don't deal with them well, absolutely, the single payer is going to be right back at it. The only other thing I'd add, though, is if you look at these other countries, like the UK and like others that have been single payer, they're actually expanding their private side of health insurance. Yeah, they've still got the social insurance base, but the private sector side is growing, and they are actually moving towards more of the kinds of payment incentives that I talked about today based on performance and results, and even some beneficiary, even some consumer incentives. Why? Because they have some of the same kinds of problems with quality that I talked about here.
I'm not saying it'll be a perfect system. There are no perfect systems. But remember, the boiling of the pot
stay tuned.
is human lives. That's what's boiling.
When I'm back in 5 years, we'll probably be talking about single payer.
Ken Chan, University of Texas. In our conversations with David Blumenthal, he's on to your third option in a very big way, and I think that is the most constructive. Question, you've headed two agencies that can look at new technology from the point of view of is it efficacious and is it safe, but you cannot, as I understand it, make a judgment on the basis of its relative effectiveness compared to existing technologies and or whether a drug really is a major advance over another drug. We now have this effectiveness initiative. Do you, in your view, would you like to use the data that comes out of the effectiveness initiative and apply what we know about cost effectiveness to the decisions made by those two agencies, CMS and FDA?
Well, I absolutely think we need better evidence on cost effectiveness, and we need to find the most effective ways to use it. I'm actually on this IOM panel, as you're an IOM expert yourself, that's going to make some recommendations about priorities for how the comparative effectiveness spending should be used. And in our committee, there's been a lot of discussion about, there's no disagreement that the information should be used. The question is just what information and how can it be used most effectively. And I think it's actually a good debate for the country to be having right now. You all may have seen President Obama actually start this debate. He had some comments recently to the New York Times about his experience when his mother died, and with his grandmother more recently, where he said, look, my grandmother had lots of really great treatments in the end of her life, lots of costly treatments, but we need to have a frank national discussion about whether this is, really, frankly, as he's saying, the best use of resources. So this is going to be a big public discussion in the near term. Unfortunately, the debate's been framed as one of using comparative effectiveness evidence of head-to-head trials of one specific treatment versus another in a large population to reach blanket conclusions about, a technology is cost-effective or not for a broad population versus people who are saying, we're headed towards more personalized medicine, more predictive medicine. You can't make these generalizations from traditional clinical studies, which is what we get if we set up a comparative effectiveness program. My own view is that you can't actually get to personalized medicine unless we do a much better job of developing evidence on whether these combinations of genomic tests and targeted therapies really do work in particular populations of patients. And so we really need to develop this kind of comparative effectiveness evidence. And if we do it right, absolutely, it should be applied. It just may not be applied. The best way to apply it may not be in the form of broad coverage decisions. This or that technology is worth it, it's not worth it, but maybe in the form of payment reforms, benefit design reforms. Medicare is now doing something we started while I was there, what's called coverage with evidence development, where they'll provide some coverage, but only in the context of figuring out better which patients really benefit from the treatment, and that seems to be working in some areas where we've applied it. So this is, I don't think there's a simple answer to the question, but I think it's absolutely going to be a key part of resolving some of the problems that I talked about today.
So do you think we'll be able to read an IOM report and find out?
Yeah, stay tuned. It's coming out at the end of June. Thank you all very much.